I would request Professor Somani, who's been very gracious in sparing time and coming to our webinar, to talk about the contemporary evidence for use of local anesthesia, PCNL. So, Professor Somani, the stage is yours.
Thank you so much. Thank you. Faisal, if you wouldn't mind stopping your screen share so I can share. Thank you. And thank you to the Pakistani Association, to Hamad, Faisal, amazing talk. Dr. Rahman's talk was very, very good. And in fact, I have learned a lot from it. So thank you for the invite. And I'm hoping to share some evidence now around what is out there. There will be some overlap with the talks that have already happened. I have to say, Dr. Atar Rahman, you need to publish your results. Your series is probably one of the largest, so please do it. Guidelines we have already mentioned. I mean, large stones, of course, PCNL will have a role. If you have trouble with smaller stones with other techniques, PCNL still has a role, mainly because of the minimization. You know, PCNL has now become, it's no longer the 30 French or the 26 French like we used to know. It's much smaller now, and most people are doing minimally invasive PCNL for smaller stones, especially if it's in the lower pole or if the anatomy is not very favorable. Although it is strongly challenged by ureteroscopy, I would add, because ureteroscopy has also moved on. Nevertheless, let's have a look at the guidelines which from the IAU, and again, they say similar things: renal stones, large lower pole stones, or in the calyceal diverticulum. In fact, even ureteral stones where you have really difficult access from below, or it's not possible because of stricture or because of the anatomy, or because the ureter, the stone is quite impacted and you don't have any way of getting from below. There are some contraindications which we need to be aware of as well, which is untreated UTI, maybe tumor in the access area, and of course pregnancy, although it's a relative contraindication. Some things to consider. Again, there will be some overlap. There are patient factors, urine culture beforehand, antibiotic usage, imaging and radiation use, and we've already heard how ultrasound should be used primarily or in conjunction, related anatomy to the access itself, positioning of the patient, miniaturization, which I think has completely revolutionized PCNL, exit strategy, and then avoidance and management of complications. Very important, because no matter how good you are, you will have complications, and then how do you go about managing it? And there are some factors that influence these aspects. The positioning, of course, is important. Planning, technique of puncture. I think puncture, we'll all agree, is one of the most important features of PCNL. How do you specify the system for adequate dilatation or adequate puncture even? Caliber of the tract. And then there are special situations when it's not dilated or it's completely impacted. You know, there is hardly any space. Now, what do we want? Of course, we want stone clearance, and ideally we want 100% stone clearance. If it's not possible to clear it completely, then at least we want to clear the pelvis to improve the drainage, clear the lower pole, because our other fragments can hopefully improve lithotripsy or respond to lithotripsy, and minimize the residual fragments. So I'll just spend 2 minutes talking about miniaturization. I think the surgical time, bleeding, pressure, pain, hospital stay, they're all slightly different to the standard PCNL. Some in favor, for example, bleeding, pain, and hospital stay. Some not in favor, because surgical time would be slightly longer with miniaturization, pressure would be slightly higher, and then functional outcome, of course, is much favorable for miniaturization. Ultimately, you need to individualize treatment for patients. You can't say, I'll just choose just technique for all my patients. I think you have to tailor what you want to choose for the patients. If you look at the different proposals, what is mini? I think there was a lot of confusion. It's still not clearly defined in my view. Some people say, you know, over 16, 17 is mini, up to 25, but we still don't know. We do know that there are some very small, medium, large, and then standard or extra large, as we would call it. We've already looked at some pioneers of how standard has gone to mini, ultra mini, super mini, and then micro. And it's all down to the diameter of the sheath, which has completely changed. Cost-wise, they're very similar in terms of the real cost, in terms of the procurement. Luckily, at PCNL, unless you're using balloon, there is not that much cost really, or if you're using laser fiber. I quite like this classification, actually. It's quite nice. XL, large, medium, small, extra small, similar to the clothes we wear. An irrigation flow, continuous flow, closed or open flow. diversion, what do you do afterwards? It's quite a nice way of presenting and maybe comparing different type of aspects of PCNL when you're performing it or afterwards. What are the newer advances? I think most of the newer advances in PCNL relate to needle guidance and making the puncture and needle tracking. So your optical system, you can use Urodana CT, although it's very expensive, almost 3 or 4 million. You have iPad-assisted PCNL. Really, there's been a couple of studies, but not much. Polaris technology, 3D ultrasound, real-time virtual sonography, Sonic's GPS, which is GPS tracking, electromagnetic tracking, robots. To be honest, a lot of buzz is around there, hopefully some of which will deliver in the next year or two, but it's still quite preliminary, most of it. Let's talk about why I was given this talk, which is what is the evidence around the PCNL and the local anesthesia. So we sift through a lot of data. Ultimately, we had 6 studies in this. We included patients, obviously studies that reported on PCNL for kidney stones, with or without sedation, but under local anesthesia in the English language with a minimum number of patients for all age groups. And we excluded where PCNL was done for non-urinary lithiasis condition or stone-free rate was not reported. Now, as you can see, China clearly outflanks most countries when it comes to local anesthesia PCNL reporting. A lot of these patients were males predominantly, and the BMI was also low, and quite a few retrospective studies. Nevertheless, it puts a good foundation to PCNL under local anesthesia. Now, when we have a look what people have used, primarily lignocaine from the skin to renal capsule and underlying parenchyma. That's what most studies have used, in about 15 to 20 mils of it. And I think a lot of pain comes either from the skin incision or when they're from the renal capsule. So it's very important to go deep and anesthetize the whole tract, including the capsule. What about the outcomes? I think most studies reported prone position. Access was through ultrasound in 4 studies and a combination of ultrasound and fluid in 2 studies. Sheet size, mostly over 22 French, although 3 minimally invasive techniques were used with under 20 French. 1 tract in most, combination of pneumatic and ultrasound in most. Nephrostomy completely used in 5, and 1 they used with suction sheets, 2/3 were tubeless. Operative time sort of between 40 and 90 minutes. So what were the outcomes? It included almost 3,600 plus patients. Stone-free rate of between 70 and 94%, which is not bad, I would say. So again, this is important. How many patients actually don't tolerate it? So I would say of our cohort that we reported in 1 in 200. So 19 patients in total, 6 were converted to general anesthesia, 2 were converted to epidural anesthesia, and 11 had the procedure terminated because they couldn't tolerate or were not fit. Overall complication rates varied from 5 to 21%, similar to the standard PCNL and the general anesthesia, but mostly were grade 1 or 2 complications, and grade 3 or 4 were quite few comparatively. So let's talk about where I think the future will be for this technique. I think we do need more comparative study between local and other different regional anesthetic techniques, which was beautifully presented by my previous speaker. Perhaps more report on stone complexity, comorbidity, frailty, and some related tools, because yes, it can be done, but which is the patient cohort we want to choose? Is it all patients? Is it some patients? And there needs to be some clarity around it. Maybe we need to have some other functional recovery and biomarkers that can tell us the patient is now recovered or based on their mobility, because we don't understand quite. Some patients still stay for quite long in the hospital despite it being local anesthesia. And maybe we need to improve techniques to identify when we can send them home, or early discharge can be done. And hopefully more focus on probably establishing proper dose and type of local anesthetic use. And I think that will be quite important to standardize how everybody does it and not just selected centers. We also looked at mini PCNL in the local anesthesia, and I'll give you a snapshot. In this, we had 10 articles and just 1,663 patients in total. Stone-free rate again was quite good, 85 to 93%, with conversion rate very similar to the standard PCNL. When we look at operative time, the first look, it was quite large for some patients, probably because it was a smaller tract and you had larger stone volume. But when they had a second look, it was quite quick, where these are patients who had a nephrostomy left behind. Complications have a wide variation, and that is because of the way it was reported. But majority were grade 1 or 2 complications, and none had grade 5 complication. Blood transfusion, again, varied from 0 to 4% across the studies. But I think the review clearly showed that minimally invasive PCNL under local regional anesthesia is feasible with good stone-free rate and low risk of major complications. This is something which is currently in press, regional versus general anesthesia, and we've done a meta-analysis of this. So this is just the first look. And in this, we had more than 3,800 patients and 13 articles, mostly under local, but equal sort of 1,600 under general anesthesia. And what did the results show? That the results were very comparable between local anesthesia and general anesthesia. However, the local anesthesia group had reduced rate of nausea and vomiting, as you'd expect. Immediate postoperative pain, to my surprise, was also lower in the local regional anesthesia, and major complications and length of stay was also lower. So I think, although we can't say we'll change the practice and we'll do more and more local anesthesia, I do think that patient selection is important, and counseling and decision-making for these procedures to get the best clinical outcome. And clearly there will be a group of patients who are not very well and who local anesthesia is the default choice, but yet there will be some patients where you can give them an option of a general versus a local or regional anesthesia. Just briefly talking about mini PCNL, I think mini PCNL, if you look at the last line, 1 grade 4 complication, rest all grade 1 and 2. And this is the beauty. I think mini PCNL is really reduce the rates of complications, especially major complications. And equally, I think we will come with the local anesthesia and regional anesthesia, day case PCNL, and that is going to come as well, where you have clear set of parameters of preoperative, intraoperative, and postoperative, where you can have safety measures in place, but we should be able to do more and more of these cases as a day case procedure. I don't think it's a must, but when there are bed pressure, especially in the Western world, in UK, there's hardly, there's always a bed crisis. Then doing this and following some basic steps will really help you to discharge patients the same day. There's some other aspects. What about tubeless PCNL? Where can you do it? This is a nice paper that shows in the uncomplicated index patient, you can do totally tubeless, where you have little blood loss, perfect puncture, no perforation, and general fit patients for stones less than 2 centimeters. But if you have larger stones, residual fragments, etc., then you still need to put a safety tube or a nephrostomy tube, especially if you're worried about bleeding or extravasation. This is going back to 2014 when I did my first ultra mini PCNL. And in fact, prior to that, I'd done an endoscopic combine using a slightly different technique. And we have come a long way in the last 10 years now, because at the time it was quite novel. Now it is almost standard of care. Just to also say, for tubeless procedures, this is a good algorithm to consider. Do you need a second look? No. Do you need an anticoagulography? No. Can you remove the sheath? Yes. Is it bleeding? No. So do it tubeless. Then you don't need to. So it's a good algorithm to remember when you want to do a tubeless procedure for these patients. We have recently also looked at artificial intelligence as a part of kind of predicting stone-free rate. And I think the watch the space, because AI is coming in a big way in this area in terms of PCNL outcomes. Similarly, mortality still happens with PCNL, luckily quite infrequent. And I think we still need to worry about sepsis as a cause of mortality. That is not going away. So you must make sure the patients have got sterile urine culture with adequate antibiotic prophylaxis. Otherwise, we'll see, and this is the role of AI, you can see in PCNL, how it's just completely, in the last decade, it's gone from naught to almost 400%, and mostly to do with targeting and training. And I think the future looks very bright. So just to conclude, I think PCNL is absolutely feasible in the local and local regional anesthesia. You might need to modify strategy slightly to, depending on the stone and the skills you have. Probably avoid multiple tracks for this kind of consideration. Consider minimally invasive or smaller tubes, and maybe consider lower radiation and endoscopic combined surgery. Thank you.
Thank you very much, Professor Somani. Wonderful comprehensive review on PCNL under local anesthesia. If you have to define one ideal patient for PCNL under local anesthesia, in terms of the stone burden, in terms of the patient's body habitus, and in terms of the size implant sheet that you're going to use?
I think, if I'm really honest, probably Dr. Ataur Rahman is much more an expert in answering this, but I will start and I'll give it the dash to him because his experience far exceeds mine. If I had to choose an index patient, it should be somebody who are not obese, who are probably you can do it with a single track. I would prefer to have a smaller tube, so probably less than 20 French if possible, and you are not expecting any sudden surprises. That will be the kind of patient, but patient has to be counseled about pain, especially in our setup. We have to absolutely make sure, and you probably do need to have a backup with general anesthesia, so that if there is a problem, you don't have to abandon it and you can then convert it to general anesthesia. Although in a suitable patient who is properly counseled and you can get the anesthesia properly, that risk will be low, probably 1 in 100 or 1 or 2%, I think. But I'd like Dr. Ataur Rahman, who I'm very impressed with the series he has, complete this.
Atta, there are a couple of questions, and I think you can take up this question as well. There's another question
I think
about
there was a tract dilatation. I think somebody was.
Yeah, I mean, there was one question about how would you monitor your guide wire? Dr. Jalbani wants to know how you monitor your guide wire with an ultrasound only access.
Exactly. Yeah, what I mean, I normally use sensor wire, and I've seen invariably sensor wire will go into the ureter. This is what I've seen. And during ultrasound, if you carefully look at the pelvis and the movement in the upper ureter, you can just outline the ureter as well. The guide wire, it will show that the guide wire is going through that. Secondly, if you see my video, I clearly mentioned that the needle puncture, when you do, you take you measure it and you mark all your dilators to that level. Like, for example, it is 5 centimeter. You don't go beyond 5 centimeter. And thirdly, one of the consolation to me, one of my assistant is continuously, slowly pouring out normal saline through the ureteric catheter. So what is happening all the time, the water is coming out. If it stops, it means you are out. So quite often, what I mean, it's very rare that I've lost the track or where I have to redo it. Otherwise, if you are in, the water would be continuously coming out. You use your metal dilators. You don't go beyond that particularly mark, which you mark it. And quite often I find my sensor wire, which is going into the ureter.
So I think the use of middle pole calyx puncture probably is contributory to going directly into the
exactly. Yeah. But the sensor wire, somehow, I don't know, it is so good, you know, it makes way into particularly into the ureter. So that's the or it may go into the upper calyx. That is another observation. If it's a dilated upper calyx, it normally goes into the upper calyx as well.
I agree. I think the choice of having good equipment, basically, you know, the sensor wire, you don't have to swap it very often. You can just use that for both access and dilatation. Some people might want a super stiff wire, but I agree that it is quite a good thing to have in the
It's a good wire. Yeah.
Correct.
And I think there's another question which is I think
balloon dilatation versus serial metal dilators.
I don't, because you know we can't afford, our patient can't afford this, so we are using metal dilators. So I think it is wonderful. I think metal. Even just recently I visited guys Jonathan Glass. I've been actually observing Tip Tap. He was using ultrasound for puncture, and then remaining he used to use fluoroscopy. Jonathan Glass is saying we are just using the metal dilators. And I think it's very safe. You don't go beyond the olive tip, and I think it's very, very safe. So I think
I would slightly disagree. I mean, I'm not disagreeing that one is better than the other. I think they're both doing the same job. I think a lot of time the primary decision about not using metal is because you have to go in and out a few times. And with lesser experience, it is probably easier to perforate. I'm not saying you will, but probably easier to perforate compared to balloon. But of course, it is the cost factor then, because balloon is expensive, metal detector doesn't cost anything. So
yeah, I think that's a good point. But I think with your experience, you know exactly where this metal dilator is. For the mortal souls like us with not that much of an experience, initial fluoroscopy availability could be really beneficial until you develop enough confidence in being ultrasound alone as a modality. So,
in fact, Professor, I would like to add that even if you are completely confident, as a backup, you must always have fluoro. I think because there will be a case, you know, So
Professor Somani, I mean, I think if you're using ultrasound, you need to have a backup. But I mean, I like there's a question about the diverticulum. I think that's the most difficult area to go in and get the stone out. And quite often I have used then fluoroscopy. So I think one has to
also for tract dilatation. I think tract dilatation you can do ultrasound guided, but it's not easy. I think that's where fluoro really is quite helpful, and you must, or most people need to use it.
Right, we have exceeded our time, but I think it was such an interesting deliberation, and I'm really grateful to all the three speakers who have done a wonderful job. I'm thankful to Professor Ataur Rahman for his brilliant demonstration of the technique and the evidence about ultrasound usage. Dr. Faisal, really enjoyed your slides and remembered me the days of medical college, looking at those anatomical details of the muscles and their attachment. So thank you very much. And Professor Somani, it's really an honor to host you this evening. And we're really grateful for your wonderful talk. So have a very good weekend. Thank you very much for being here this evening. And I hope the delegates have also enjoyed these three wonderful presentations.
Thank you, Amar.
Thank you for your kind invite.
Thank you very much.
Thank you so much, sir. Thank you so much.
Nice weekend. Very nice weekend.
Bye-bye.
Bye-bye.